Is it in the posterior? It would be spina bifida. We will not go to the neurosurgery of the pediatrics, but I wanted to show you some of the picture how the problem is. Anencephaly, they don't have a skull wallet. Both hemisphere is gone. Even optic nerve is gone. It would be blind. Maybe they would be alive. Otherwise, they would be dead on the abdomen of the mother. So they will die in the first days, not compatible with long-term survival. So you can go for therapeutic abortion in such baby. Encephalocele, the occiput has the problem. 50% survive, 75% they have some mental deficit. Depends on the severity, we will think about therapeutic abortion or not. But here about spina bifida, you can see the skin is not closed. There is no mass, but you can see the neural tube is there as well. Sometimes it is occulta, sometimes it's apparata. Apparata means open, sometimes it is occulta. And it is interesting, 20% of adult population, they have spina bifida occulta, which is not clear to be seen. Only by MRI, by CT scan, you understand there is something wrong on this one. And in Iran, military service is compulsory, but for these people, they can go home without military service. Spina bifida occulta, yeah. Why it is important for you? Because if you saw a patient, the pregnancy of mother, and you see there is something wrong on the baby, you will ask them, please go, for example, to Tehran or to go to Central Province, because you should do surgery after delivery of the baby in 48 hours. Otherwise, they will be at risk to have the meningitis. They should do surgery to, as soon as possible, close the meninge and remove this kind of mass somehow. They should have antibiotic in this regard. Otherwise, the baby would be at big danger of death. So, the baby started the antibiotic, the surgery has done, the neural tube defect and skin was closed, ventricular shunt to relieve hydrocephaly was done. Then they realized there is no movement on the foot. This means there is something wrong upper at the size of the injury. Even they should do catheterization to empty bladder, means both neuron for parasympathetic is involved as well on that kind of patient. So we do some examination in this regard to realize how is the big danger or not. Location of defect is important. Outcome would be different from each other, but remember, 75% of spinal bifida patients, they are normal, intelligent. So you can't go for therapeutic abortion because the IQ is fine. So after 9 months, there is good developmental progress. The mother says the neck is stiff enough. He can sit, he can talk, something like this. This means the development goes well. Of course, not sitting supported, minimal use of leg. His parents speak, what is the recurrence risk? We wanted to have another baby. When they ask, can I marry this lady? Can we have for another baby? These are all the questions regarding recurrence risk. Recurrence risk means wuqu'u mujaddad in Farsi. How would be the risk to have another baby with this problem? Or shall I marry this lady because we are worrying about a disorder or baby? These are the different way of the question in this regard. So to find this question, the answer will be empirical risk. You will write it down. Cleft is empirical risk. Prostate cancer, empirical risk. Neural tube defect, empirical risk. Because you can't remember all these kind of numbers. We say neural tube defect is heterogeneous. Headache is heterogeneous. You have a headache because you had a smoking. You have a headache because you didn't sleep very well last night. You have a headache, maybe you have glaucoma. You have a headache because maybe you have a brain tumor or maybe dental problem because of that you have a headache. The neural tube defect is heterogeneous. It can be due to trisomy 13 and 18. It can be syndromal, it can be isolated. Isolated means the only organ involved on that patient is neural defect. It will be isolated. If it's isolated, the risk for first degree relative would be 3 times more than normal. Recurrence is 3 times more. Second degree relative, 0.1 times more. Third degree, 0.117. So this means whoever the family member affected is distant, the risk would be less. Somebody, a lady come, my sister had the breast cancer, it would be high risk. Somebody says, no, my first cousin had the breast cancer, the risk would be less. Closer, higher risk. Distant, lower risk. So by this you can find out, but remember to check, is it isolated or is it a syndrome or is it a chromosomal disorder? Sometimes we put it as a recurrence relative ratio this way, or we put it this way: 1 in 40 for the child, 1 in 50 for aunt and uncle, 1 in 200 if a cousin is involved. Neural defect, an ideal model for studying a multifactorial disorder. Exactly the same will be for the hypertension, for the diabetes, and for the others. Okay, how we do hypothesis, how we do estimation about the genetic in the multifactorial disorder? As I said, we have a normal distribution and there will be an additive effect when the disorder happens, otherwise they will be fine. First, they put it as a threshold model of liability. Liability means how predisposed to disorder. After this threshold, they will be affected. Before this threshold, it will be not affected, it will be normal. They realize this way is much better to understand rather than a single gene mutation or for Mendelian ones. This can be a better explanation. Then they realize the liability would be changed from ladies to men based on different disorder. For example, you say thyroid disorder would be much more in ladies, or cancer would be much more in men, something like this. These are different liability based on the sex we have. The threshold would be changed. Then they said liability is very vague word. Can we do a calculation named as a heritability? Heritability is liability plus calculation. We check the variance in dizygote twin minus variance in monozygote twin divided by variance in dizygote twin. It's a little bit confusing, but forget about how this is calculated. This one is very important. Frequency of some of the multifactorial disorder and heritability of them. For example, schizophrenia, the risk is 1% of the people will get the schizophrenia. If somebody says in my family 3 of them has got schizophrenia, it means it would be familiar on that family specifically. Heritability is 85. But for congenital heart defect, the frequency will be 0.5, which means 1 in 200 will get the disorder, but heritability is 35. This means schizophrenia is much more genetic than congenital heart defect, which is much more environmental. This is the system, how this model is working, heritability. Heritability in the behavioral genetic. Same calculation for the multifactorial disorder has been done here. As you can see, anxiety, bipolar mood disorder, depression, post-traumatic stress disorder, schizophrenia. As you can see, twin study and a sleep-based study helped a lot to understand heritability, which means, for example, bipolar mood disorder is much more genetic. Schizophrenia is much more genetic. Compared with the others, it seems to be a little bit much more environmental. Just as a big face, I showed you these pictures. Another issue, Unlike Mendelian inheritance, the recurrence will be increased when more than one affected. What does it mean? We say thalassemia major is a single Mendelian disorder. So if a family says my 5 brother has got thalassemia, the risk would be same, 25%. But if somebody says in my family 5 of them has got diabetes, the risk would be increasing. The number is important for the multifactorial, but not for the single gene disorder. The next issue, more serious effect, higher recurrence risk. For example, somebody says we had anencephaly in our family, the risk will be higher than somebody says a spinal bifida happened in our family, because it is much more serious. Somebody says my baby is on cleft lip and cleft palate together, both sides. The risk will be much more higher than a family when somebody says only my son has got cleft lip. More severe, higher risk. More number affected, higher risk. These are some of the role on the multifactorial recurrence list. Why this happened? Why severe much more? It means that it is severe, so there is greater load of allele, greater load of single nucleus polymorphism, or severe environmental effect result in the much more severe disorder. So the risk would be higher. Okay, this is the point I said, this sex versa. We said neural tube is much more in the lady. If a boy has the disorder, the risk, the risk would be much more. It says the disorder usually occurs in male. Then a couple with an affected daughter has a higher risk than a couple with an affected son. Exactly the same is in the cleft lip and palate. Another risk, based on the population study, we can find out some of the people are at risk for neural tube defect. For example, the mother who has got valproic acid. Valproic acid is a drug usually used for seizure. The mother who taken valproic acid, they are at risk to have a neural tube defect patient. Maternal type 1 diabetes mellitus. Mother has diabetes type 1, at risk to have a neural tube defect baby. Obesity of the mother. Race and ethnicity. Race and ethnicity. Race means nejad in Farsi, Iranian Aryan. But we have 17 ethnicity in Iran. Turk, Lur, Baluch, Arab, Gilak, Fars, these are ethnicity. In the USA, white are at risk to be a patient with neural tube defect, more than African American, more than Asian, based on the population they have done. And the last but not the least, this one, they realize poor people are at risk to have a neural tube defect. Then they realize the poor people has less folic acid, they will be at risk to have a neural tube defect patient. So this one showed itself as an environmental factor, very important for neural tube defect. Then they have done some trial. They realize a lady has got neural tube defect, then they give them folic acid. They realize 7 times would be less the mother who has this compared with the mother who didn't have the folic acid. The risk will be 7 times less. Then they started a public health initiative. We have it in Iran. All the lady at age for the pregnancy, we give them 1 milligram folic acid. If they are more than 35, we give them 5 milligram folic acid. A lady who has a patient with neural tube defect, we give them 5 milligram. But in the USA, they have it 0.4 milligram, 2 or 3 months before pregnancy and 2 or 3 months after pregnancy. Important issue is we should start it before pregnancy. After pregnancy, doesn't matter, it doesn't work. Okay? They realized the risk would be much, much less. 75% risk of neural tube defect was decreased by this way. In the US FDA, they did fortification. Anybody knows what is the fortification means? You see in the supermarket.
Enriching foods with certain minerals.
Enriched with mineral, exactly. For example, you go to the supermarket, they say this milk has got vitamin D, this bread has got folic acid or something like this. They add it to the, here enriched cereal is there, and with folic acid they did 19% decrease. It is very important in the population. 19% is very important. We have enrichment or fortification with vitamin D, with folic acid in Iran as well, which is very important. So they realize, okay, this environmental factor can help a lot. So please, anybody in your family wanted to go for pregnancy, ask them to have 1 milligram folic acid 3 months before pregnancy, up to 3 months after pregnancy. If they had a neurotrophic defect in the baby, or if they are more than 35, give them 5 milligram folic acid. It is a vitamin without any danger. Then we find out, okay, what is the molecular basis behind that? What this folic acid will do? We have a gene named as MTHFR, methylene tetrahydrofolate reductase. Very important polymorphism in that one, and you can see there is a polymorphism here, twice as the control for polymorphism they do metabolism. And I did a search and I realized MTHFR is important for all this disorder. Vascular disease, neurotrophic defect, cleft palate, hypertension, preeclampsia, thrombosis, even glaucoma, even cancer. It's a very important gene. So if you have an enemy, you can ask, oh God, please do an MTHFR mutation on my enemy, so he would die very easily. So this polymorphism is very important in the MTHFR gene. Of course, this is a big gene, and we have several exons, but some of the polymorphism on that gene is very important, and you can see the folic acid as an environmental factor will work on this MTHFR, so you will be at risk or you will be normal.
It's about that you say before pregnancy by 3 months, getting 1 milligram of folic acid. Each month getting 1 milligram.
No, every day.
Every day.
Yeah, 1 month is nothing. I have 75 kilogram, 1 milligram in 1 month, nothing will happen. The only 1 week drug is vitamin D. The people who are vitamin D, we know it is important for osteoporosis. Nowadays we understand vitamin D is needed for immune system, for diabetes, for hypertension, even cancer. We ask everybody after the age of 40 to have 1 vitamin D 50,000 international units per month for the normal people. Whoever are on less vitamin D every week once. But folic acid every day. Thank you for asking. Every day on me. Yeah. So this case report I had before, they are asking, okay, we wanted to go for another baby. What shall we do? We say pre-conception folic acid, as I said, every day, 1 milligram for usual lady, more than 35. Or if they had another baby with neurotrophic, they should go for 5 milligram per day. Yeah, per day. The lady on pregnant, they are asking, do you have any test to be sure this baby is fine, the next baby? Hopefully we have. You see, the normal baby has got this maternal serum alpha-fetoprotein. It is a screening test. We take a sample from mother, we check alpha-fetoprotein in the mother. These are normal baby. It would be low in Down syndrome. It will be high in the spina bifida, open. In occulta, there is not this one. As you can see, we have some cover, some overlap. Because of that, we say a screening test. If these 3 would be divided from each other, it will be a diagnosis test. There is no false positive, false negative if they are divided. Otherwise, we have cover, we say overlap, we say it is a screening test. In Down syndrome, it would be decreased. In the spina bifida, it would be increased. But we should do some calculation to be sure. And when we saw this is increased, then we ask for sonography to be sure if the diagnosis is right or not. sonography would be diagnosis test, but alpha-fetoprotein would be a screening test regarding neural tube defect. Okay? If you remember yesterday talk regarding Down syndrome, I showed alpha-fetoprotein it will be decreased, beta ICG would be increased. That's a screening test, Gani in Farsi language. So, we close this part, we will go to cleft lip and palate, then you have a break for first session. Exactly the same for neural tube defect is here. Is it bilateral or is it unilateral? Is it only cleft lip or is it cleft lip and cleft palate? Sometimes you have to wear a gloves and then check the head of the, the part of the mouth to be sure there is no cleft palate. Otherwise you miss the patient. It is much more in male, much more in ladies. Asian, more than Caucasian, more than Asian, African-American. So ethnicity is important. Again, it is heterogeneity, single gene disorder, multifactorial, chromosomal, and teratogen exposure can result in the cleft lip and palate. You should ask, have you had a drug before pregnancy? Are you using something? Is there anything else in the other body? Heart is any problem? Kidney has a problem? Hand is any problem? To be sure, is it chromosomal, is it single gene, or is it multifactorial? Bilateral and cleft lip and palate together, it will be much more severe, so there will be much more risk for the other family member to have the disorder. And the number of people is very important to see how would be empirical risk and increased risk. And you can see the number. I'm going faster because there is a lot to tell about multifactorial. So to conclusion for first part, there is no specific pattern in the family. If you see a specific pattern, think about a single gene disorder. If somebody says, my grandfather has the diabetes in the age of 40, because diabetes is for the age of 60 and 70. Grandfather 40. My father had it in the age of 41, 42, but again it is young. And I have it, it means inherited. We have a diabetes inherited. I will show you the picture of that in the next part of my first session. It is a single gene diabetes. We have type 2 diabetes in this as a single gene disorder. So a specific pattern can be a conclusion, it is a single gene disorder. No specific pattern. For example, you say, three in my family has got diabetes, my aunt, my grandfather, my wife. They are different from each other. No pattern, which means it is multifactorial. Familial tendency is very important. Less incidence figure in close relative rather than single gene disorder. All group, congenital, young, adult, and late onset, they are at risk for multifactorial disorder. Please take a break. 5 minutes, we will start. We do calculation of relative risk ratio in the family of the affected person divided by the prevalence population. If the number would be 1, means this 2 number is the same. It means that this family is the same as general population. For example, in Iran, we say the risk for the diabetes is 12%. If somebody say, okay, my family is 12%, you can say you are at the same as general population. And we have this relative risk ratio for some of the disorder. Here, for example, we say schizophrenia, the relative risk ratio in monozygote would be 48, in sibling would be 12. Because they have the same gene. For example, one of the monozygote twin has got the schizophrenia, the risk would be 48 to other one to have it. In the sibling it is 12. But here for multiple sclerosis, it's 800, sibling will be 24. This means MS is much more genetic than schizophrenia. Also, we can study the twin, comparing the dizygote twin with the usual sibling with the monozygote twin. Easily to understand how much is the percentage of the genes and environmental affecting to have the same disorder in the sibling and twins. Here you see, for example, epilepsy. For monozygote twins, 70%, for dizygote twins, 6%. See, having the similar gene, how nearly 10, 11 times much more risk to have the disorder. Type 1 diabetes, 4.8 and 40, 10 times much more, 9 times. Something like that. Because of that, we can say how load of genes, how effect of environment can help to have a disorder or not. Let's go to how we candidate a gene for multifactorial disorder. We have two systems. Affected pedigree member method. We need two affected person, two normal from the same family to check for that. It is not an easy job. We go for association. It is very important to know. We go for linkage study, for single gene disorder, for Mendelian. We go for association for multifactorial disorder. Linkage means if I have two affected persons from the same family, two normal, we can find out, okay, this gene is responsible for disorder, for Mendelian one. Association, we have to go for population. I need a group of normal people, a group of affected people, do some study in this regard to find out is it candidate gene for the disorder or not. I will explain much more. The association is model-free and non-parametric. One gene is not enough to have the disorder. This is affected SIP pair, comparing what the genes we have and how we estimate to have. So we can find out, but it's not an easy job. I will not go through further detail of that. I will go to the association. It will be on the population. We ask, there is 100 people from diabetes camp, 100 people from normal group. They will come together. Control group is very crucial, and we do some calculation in this regard. For example, look at this one. We say allele 1, for example, A, C, G, T. That's for allele we have. In general population, 25% they have allele 1. But in affected, it would be more than 75%. So we can say this allele are associated with the disorder. You see, normal people affected. If something would be much more in the group of disorder, it would be associated. Of course, in the single gene disorder, it would be 100%. Everybody who has the mutation has the disorder. That will be 100%. Forget about 100%. In the multifactorial, this will be as a schematic of what's happening here. How we candidate a gene? This is very important. There will be questions out of this slide. By biology, we know KIR6 responsible insulin secretion. So polymorphism in that gene can be associated with the diabetes. By positional cloning, we know calpain is a gene responsible for diabetes. Polymorphism in that gene can be responsible for that disorder. Moody, maturity, onset diabetes of youngs. It is a type 2 diabetes in the young. They are not obese. Diabetes is for the age of 60. They have it in the age of 40. It is a single gene disorder. You can see vertical inheritance. It is autosomal dominant. Usually, in the age of 60, we have the diabetes. Here, we have the age of 35, 40. The grandfather has it, daughter has it, grandson has it. So it can be Moody. We have at least 6 genes responsible for Moody. One of them is Moody 4. IPF1. By human model, we know this type 2. In the young, polymorphism in IPF1 gene can be responsible for type 2 diabetes. The last but not the least, animal model. We have a mouse model. You know, mouse and human are 97% similar in the coding gene. So we use usually mouse to be a model for human disorder. We check mouse for different drug. 97% similar. Chimpanzee is 99% similar. So nobody can say, oh, I am human being, I am the gift of God, I am the powerful, I am Hitler. You are 99% same as chimpanzee. We are not talking, you are talking. You see? Of course, why we are not going for chimpanzee, we go for mouse, because mouse is very quickly have pregnancy and birth. We are using them, and we have a joke, we say every 6 mouse is enough to make a paper for the pharmacologists, not for the geneticists, of course. But same similarity. So what we do, we say, okay, the genes responsible for insulin secretion can be responsible for diabetes. Exactly the same genes may be responsible for hypertension. Same gene for the obesity. We do candidate gene. So we check for association in the group of disorder, in the group of normal we check. We say, okay, in the Iraqi population, this polymorphism is not associated. We make a paper. Then we check the Germany, then we check in the Pakistan, then we check it in Iran to say, is this gene polymorphism in several populations have the same association or not? Every time should be associated? No, because they have a different environment. Maybe this polymorphism not, but the other one is important. Every 1,000 or 3,000 we check for SNPs, and we should check all of them. If there is positive association, we should replicate in the other cohort, in other country, and we do functional analysis. By functional analysis, we say, okay, by this polymorphism, this happened, this result in this, and in this will be on the pathway, same as what I show you in the MTHFR. If there is negative association, again, we should repeat in the process in another country, or we can say, okay, this polymorphism is not working in the Pakistan, not working in India, so forget about this polymorphism. This polymorphism is not essential or functional on that disorder. The people put it out. So this one is very important, this one, so remember this. Then we check for the power of the study, same as p-value for the usual original article. We have odds ratio dividing the allele in the group of patient and the group of control. We do odds ratio, we say, okay, this study is powerful, this study is not powerful, the case group is not enough, the control group is not enough to understand this paper is good or not. So, that's important slide. Linkage in the family, association in the population. Linkage is good for single gene disorder finding, association is good for multifactorial disorder finding. When we think one gene is enough for single gene disorder, we will go for linkage. When we say one gene is not enough, we will go for association, and we check different countries in this regard. Okay, I can conclude now for multifactorial. I will go to another part, mitochondria. It is very important. Mitochondria is again non-Mendelian inheritance. We say it as a cytoplasmic inheritance. We have 16.6 kb mitochondrial genome. They encode 37 genes, 2 ribosomal RNA, 22 tRNA, and 13 polypeptide encoding gene responsible for respiratory chain complex. We think mitochondria has 3 important issues. They generate energy by oxidative phosphorylation. They have a byproduct reactive oxygen species, which is mutagen, and they are very important for initiation of apoptosis. Maybe in future, hopefully, you will find a drug work on mitochondria, and it will help to control the cancer. It is very important. Everybody around the world are working on this gene in this regard. They have different characterization, mitochondrial genome, comparing with nuclear genome. Of course, nuclear genome is very, very important. Mitochondrial genome is very simple. They are circular DNA duplex. Circular DNA duplex, same as plasmid in mitochondria. Is not same as double helix for the nucleus DNA. They are extremely compact. There is no intron. There is no repeated area. Very few. 97% of DNA sequence would be used for coding. The genes lack intron. It's tightly compact. 1 in 400 base pair would be a gene. 450 base pair as an average is a gene. But for the nuclear genome, they are much, much bigger. And it is interesting, we have 2 copies from single gene, one from father, one from mother. Here we have very multiple copies for mitochondria. 5 to 10 mitochondrial copy, and from each tissue to tissue, it's very different in the mitochondria. But for the single gene, is exactly for the nuclear genome, is exactly the same. Here are some comparison between these two. Please read this. Also, remember we have heavy chain and light chain in the plasmid, in the mitochondria, which is not the case in the nuclear genome. Heavy chain encode 28 gene, 9 gene by the light chain. It is very interesting how we compare these two. Nuclear genome is 3.3 times 10 power 9. Here is only 16,000 base pair. Single gene are 20 to 30,000 gene. Here we have only 37 gene. 1 in 40,000 base pair would be a nuclear genome. 1 in 450 would be a mitochondrial genome. The size is very, very less than the nuclear genome. The coding part of the genome would be only 3%. In the nuclear, here is 93%. You see how different they are from each other. Exactly the same one. We say 99% chimpanzee, same as human being, but the part they are coding in chimpanzee would be different from what we have in the human being. Please read the others, I will not go through them. It is interesting to understand the plant has got much more mitochondrial genome than human being. Human being is 16,000 base pair, Drosophila 18,000, yeast 75,000, turnip 200,000, corn 500,000 base pair. What is interesting again, the number of genes is nearly 20, and the other much more of that would be repeated area. We have repeated area in the plant, but we don't have repeated area in the human being. Somehow we can say mitochondrial genome is much specialized in the human being compared with the other species. They have a complication between genotype and phenotype correlation. For the nuclear genome, we say whoever has got this point mutation will get the disorder. Parental has 100% usually. But mitochondrial genome, even you found the mitochondrial genome in the baby, you can't go for therapeutic abortion because we are not sure having the mutation is enough to have the disorder. So we can say there is low penetrance in mitochondrial genome. Why? Because they are multiple copy. Why? Because mitochondrial genome are at risk to have the mutation, but having the mutation is not enough to have the disorder. The last mitochondrial genome comes through mother, not from the father. We say maternal inheritance is there. We have some complication because we have mosaicism. Mosaicism is very usual in the mitochondria, which is not the case in the chromosomal or single gene disorder. Tissue and cell specificity. If the mutation would be in neuron, we will see the disorder. If it's not the mutation in the neuron, for example, it is in the muscle, maybe we will not see the disorder. The tissue is important. Threshold effect, which was the case for multifactorial, is here again. If you have more than this amount, you will see the disorder. Less than an amount, it would be normal. And maternal inheritance. Maternal inheritance, what does it mean? It will be in the next slide. At the moment, we have a calculation, 1 in 8,500 people has the mitochondrial disorder. Maybe you have by chance, you will see a mitochondrial disorder when you come to Tehran in pediatrics. You will see that they have different kind of mutation to have the disorder, but it is important to know mutation rate in mitochondria is higher than nucleus. Why? Because the proofreading system is not efficient as it is in the nuclear. Second, protective histone protein, which is in the nuclear, here is not there, it is missing. Mitochondrial DNA associated with the inner mitochondrial membrane, where the oxygen radical accumulate, and we know oxygen radical are a mutagen clearly. And the last, accumulation of polymorphism occur 10 to 17 times more than mitochondrial DNA faster. So by the mitochondria, you can go to the Mother Eve. So we can say this sample is from that population because mitochondrial genome will not change too much based on the time. You can say, okay, the people from Africa Central come to Asia, from Asia they went to Europe, then they went to USA. We can see this movement by the mitochondrial genome. Also, we use Y chromosome for male, mitochondria for mother, Y chromosome for the father. Both of them are not too much recombinant there. Here is the pedigree for mitochondrial genome. Mother affected, child at risk. Father affected, child are normal. Why? Is there any mitochondria in sperm? Yes, there is. But when the sperm mitochondria are marked with ubiquitin, when they go enter to the oocyte, they will be vanished, degraded. And it is interesting, mitochondrial DNA in ovum is 100,000 copy, but a sperm has got only 100 copy, which means 1,000 times more for oocyte compared with sperm. That's another important issue for the ladies. And it is interesting, the people who go for cloning, they use the mitochondrial oocyte and they add only nuclear DNA to that oocyte. Without that, they can't go for having any normal cloning. So, mitochondria is in the sperm, very few, but it will be degraded. But mitochondrial DNA from oocyte would be used to make the baby. We have heteroplasmy. If we go to reproductive segregation, there will go to homoplasmy. Then the disorder will happen in some, not in the all. You see, for example, when we say 1 mutation, 2, 3 mutation, 5 mutation, this is not enough. After, for example, 7 mutation, we will have the disorder. Without that, it will be normal. So because of this heteroplasmy, we will not go for diagnosis and prenatal diagnosis of the patient to go for abortion. PND is not possible for mitochondrial DNA mutation. If a mother says, I have the disorder, I don't want to have it to my child, we say, unfortunately, we can't do that. We can find the mutation, but we can't say this mutation will go to the aggregation threshold and we will see it out of homoplasmy. So this way is not easy to do in the mitochondrial genome. Here is the threshold. For example, we say if more than 60% deletion is there, we will see the disorder. If more than 85% of nucleotide 8,344 adenine change to G guanine, the MERF disorder will happen. If it would be 80%, 70%, 50%, it will not show the disorder. You see, we can find the mutation in the baby, but we can't say, is it more than 85%, so it will be phenotype. It's less than that, there will be only in the genotype. This genotype correlation is not easy the job to do. And it is very important to know mitochondria will be shown in very specific tissue, same as central nervous system, heart, skeletal muscle, renal system, endocrine system, liver system. The cell who need a lot of energy. So if you find a family, the mother has the disorder, the child has the disorder, both of them they have neuropathy, they have endocrinopathy, they have cardiomyopathy. This can be mitochondrial. Otherwise, we should check for the nucleus. Same as this abbreviation, NARP is a disorder, neuropathy, ataxia, retinitis pigmentosa. In the nucleotide 8993, G changed to be T. That's enough to have all the system involved. And all this system needs a lot of energy by mitochondria. Malaise, same, nerve, same, liver, same. So if somebody has the disorder from the mother and they are involvement of heart, CNS, eye, endocrine, you should think about a mitochondrial disorder.
Sir, all these diseases are single nucleotide disease.
They are single gene disorder, but not Mendelian because it is mitochondria. They are single gene disorder, but not in Mendelian one because the mitochondria is non-Mendelian.
So environmental exposure is not important.
Here, environment is not important. Yes. So when we think about mitochondrial disorder, ptosis, some people they don't have the power to open their eye. Ptosis. Somebody married a lady from China. Every time said, "Are you sleepy?" No, he wasn't asleep. She wasn't sleepy. She was kind of usual ptosis they have. They are usual. But if somebody in Iran, somebody have this one or both eye or one eye, we can say maybe it is mitochondrial. They don't have enough power to open even the eye. External ophthalmoplegia, proximal myopathy, exercise intolerance, cardiomyopathy, sensory neural deafness, optic atrophy, retinopathy, diabetes, dementia, seizure, central nervous system, we can say maybe this is mitochondrial. Let's go for checking mitochondrial DNA. Checking mitochondrial DNA because they have very small nucleotide, you can easily find out, okay, this is the point of mutation, and it will result in the disorder.
Sir, what is this physical exercise intolerance? What does it mean?
Exercise intolerance, for example, he or she is 3 years old, the mother says after very few walking, he says, I am tired. They can't go for any sport, they are not playing with the other children. That's the exercise intolerance, yeah. Even now, we found some of the mutation in nucleus are responsible for mitochondrial DNA. So these two islands are not different from each other. They are affecting each other. Mitochondrial mutation affecting the nuclear genome. Nuclear genome mutation affecting mitochondrial genome. This one named as mitochondrial DNA depletion. The mutation is in the nucleus, affecting the 37 genes of the mitochondria. Let's go to immune system to finish it up in 10 o'clock. Immune system, you hear a lot about this. They are try to kill invader. Some people has got a SCID, severe combined immune deficiency. We named it as a PID, primary immune deficiency, or IED, inborn error of immunity. This is the same name. Primary immune deficiency. We have the secondary immune deficiency, for example, HIV. Somebody get AIDS, before that everything was fine. Now he has immune deficiency. It is secondary. That's another issue, this multifactorial. But some people at the age of birth, they have a lot of infection. Even by the vaccination, they will die. This is a primary immune deficiency. Another name for that is inborn error of immunity, because we have inborn error of metabolism. That's another issue. Inborn error of metabolism. We have inborn error of immunity. Ask me a question.
Sir, how mutation in mitochondrial DNA causes mutation in nuclear DNA?
Sorry?
Sir, how mutation in mitochondrial DNA causes mutation in nuclear DNA?
Not affect, they are affecting, because the nucleus is needed to go for the respiratory, but not mutating on the other one. Mitochondrial DNA is not a mutagen, but they are affecting. So because we need some genes from nucleus to do respiratory oxidative phosphorylation, so this mutation can affect the other one on the nucleus, not mutating. It's not mutating. Okay, SCID is one of the primary immune deficiency, immune error of immunity. We say combined because we have two immunity, humoral and cellular. Both of them is deficient on that patient. These are the list of some of the immunological disorders. Some of them is autosomal recessive, some of them is X-linked recessive, some of them are deletion. Please read through them. I don't have the time to read to going through them, but it's easily to understand. You see, we say, okay, they are consanguineous marriage, they have SCID in the baby, so it is autosomal recessive. We see the disorder only in male, not in the female, it will be X-recessive. You can see by the family pedigree, you can say which gene is involved in that one. The treatment will be bone marrow transplantation. Sometimes you have to go for environmental enzyme replacement. The George is again another primary immune deficiency. It happened due to deletion in chromosome 22 long arm. The size of deletion is small, can't be seen on the microscope. This is one of the micro deletion. Yesterday I put it on the table. It was there. I forgot to tell about this one. But it is a chromosomal disorder, but immunological disorder. And in the primary immune deficiency disorder, which is quite nearly common, especially in the country we have consanguineous marriage, such as Iraq or Iran, you can see this kind of disorder too much. And usually people say, my son has an infection and he died. He did a vaccination and he died. Because the immune system is not working very well. They are very at risk of dying in early age. Early diagnosis and treatment is vital, sometimes only by bone marrow transplantation or by enzyme replacement therapy we can survive them. Otherwise, we should go for PND and go for therapeutic abortion. There is no other choice they have. This is the previous one was cellular. Here is some humoral immune deficiency result in different disorder. Please read through them. I don't have time to go for them. Another disorder is autoimmune disorder. Here there is no deficiency. Even we have overreaction. In autoimmune disorder there is no deficiency. We have overreaction, self-attacking. And they have again a long list. For example, multiple sclerosis is an immune deficiency, overreaction, autoimmune. Lupus is autoimmune disorder. And it is interesting, HLA, human leukocyte antigen, is the most polymorphic locus in the human genome, in the short arm of chromosome 6. We have several classes and several alleles. So we check for HLA typing to be sure this person can give his bone marrow to this person to go for bone marrow transplantation. For kidney transplantation, only the group is fine. You are O positive, I am O positive, I can give you my kidney to you for the kidney transplantation. But for bone marrow transplantation, even we should go for high resolution HLA typing to be sure this immune system will work on the other one as well. So please go through them. I don't have time to go for that. But we used HLA typing for transplantation and also for disease association. That's different from this association. For example, we say whoever got HLA-B27 are at risk to have ankylosing spondylitis. Whoever get the DR3, DR4 at risk for the diabetes type 1. Whoever has got the DR2, DR3 at risk for lupus erythematosus. These are association between immunological autoimmune disorder and HLA typing. Thank you for hearing. I know it's very hard to understand, but I wanted just to give you some names, some point. Otherwise, you have to read the book and go further. Hopefully, all of you would be geneticists in the future. But you would be bold, and you would be very old man, same as myself, playing on the